good afternoon. We're all glad you're here. We have had, this is the third week in a row that Mother Nature has separated the determined from those who choose to watch online. I'm not encouraging you to do it because being here, you have the opportunity to see, to hear directly, and also to ask questions and discuss, which is what the purpose of this whole thing is. Okay? So I think, is there anyone who hasn't been here before to any demystifying medicine session? Okay, you know what that is. What is it? Of course, the Brooklyn Bridge. And you know why we have it as a logo? Because we're all bridge builders and we're trying to connect exciting things in more basic science with major health problems and to have people communicate across the medical science East River symbolically the way the Brooklyn Bridge does. If any of you are in New York City and want to have a very inexpensive and even romantic experience, I urge you to walk across the Brooklyn Bridge from Manhattan, which is that side, to Brooklyn, which is this side, at about 4 or 5 in the afternoon when the sun is setting and you see the Statue of Liberty in the heart. And you take some wine, cheese, and your significant other. And it's a very cheap date, but one that is memorable. I remember taking it many times. Okay. You'd think I'd be. Okay, just a couple of words of things I found interesting, and maybe will help a little bit to put some things in perspective. So it turns out that the words that we associate with the entity being discussed today, herpes zoster, actually pretty much describe the disease. So the people who first described this in, I think, the 18th century, used the Greek word herpes, which means something that's sort of creeping, and the Greek word for girdle, which was prevalent in those days, now you might call it a belt, which I think it means the same, is zoster. And interestingly enough, the Latin word for the same thing is cingulus, which somewhere along the line got moved into shingles. So shingles is not supposed to be like what you see on the side of a house. Think of shingles as part of a creeping belt. And if you don't know now, you will know by the end of this session why this term is actually a very valid description, and it shows the wisdom of physicians and observers. Now, I won't dwell on this, but a couple of things struck my interest. One is that the idea that this was a disease of the dorsal root ganglia was made by a British physician who is well known because his name is on one of what used to be one of the most common forms of kidney disease, glomerulonephritis. So in those days, you could be a good nephrologist and you could observe your patients and make observations about things that were in today's world probably considered somewhat out of your ken, the need for a different kind of bridge. And then this fascinating association with chickenpox, which will be discussed and I won't dwell on, but the two things that struck me of interest that I didn't know, I didn't know it was going to be mentioned today. I found a paper back in the early 20th century where a physician took some material from a shingles patient and gave it to some volunteers. It was a different world then. And lo and behold, they came down with chickenpox. And then Tom Weller at Harvard, who got the Nobel Prize several years later, he shared it for culturing poliovirus. He actually isolated the virus. So here we are in the 21st century. So amongst the things which I trust will be discussed, and I hope you will all engage in, are important questions. Is this a benign disease? The old literature kind of makes it out to be, it's painful, but it goes away. Do people have a new infection? Or is this a recrudescence of an old infection? Do you develop immunity? And how effective is the vaccine, which we hear a great deal about these days? And perhaps most importantly, what's next? So we're very fortunate to have two NIH colleagues who are expert in this, and they're going to discuss herpes zoster in its fullest, and we encourage you, please, to interrupt if there's something you don't understand, questions, even during the course of the talk. The more questions that come in, the more you will feel involved in it, okay? Now, I had a okay, so are you speaking first, Licia, or you're going to interview the patient? Okay, so Licia Drapulich, I'm sorry. Okay, is a senior staff physician here in NIAID. She had training in infectious diseases after a medical residency. She trained at Johns Hopkins. And here, amongst her many activities, she is actually the principal investigator of the herpes vaccine trial, which you will hear a good deal about. And our second speaker is Jeff Cohen. He graduated, he's a physician, he graduated from Hopkins after a residency in Duke, and he came here as a staff fellow, went to Harvard as a fellow in infectious diseases, and then came back to NIH, I think in 1990, and he's the chief of the Laboratory of Infectious Diseases at NIAID. A very important position, and he's been there since 2010. Jeff is widely known for his work, and maybe you saw we put on the website a recent review of this topic, which appeared in the New England Journal of Medicine. So we're very grateful to both of you, and we're very grateful to you, nice lady, who's offered to come and share your experience with this group, which I described to you. So thank you. Okay.
I think it's on. Thank you very much for the introduction, and thank you, Sandra, for taking the time to come to the NIH. We're very much appreciative of that. So we wanted Sandra to share with you all her experience with shingles, or otherwise known as herpes zoster. So if you can tell us when it started, what were you experiencing, how it progressed?
I noticed. I noticed the Tuesday. I noticed the Tuesday before Christmas, the back of my hairline, I felt a little bump. Wednesday, I felt 2 more bumps behind my ear. And then by Wednesday night, I had 3 behind my ear, in my hairline, and 1 at the bottom. Thursday, I was okay. Christmas Day, I was okay. The Saturday morning after Christmas, when I woke up, the right side of my face just felt weird. So I put my hand up there and I felt all these little lumps, and I just screamed for my niece. She came in. she took a look. I've also been diagnosed with lupus, and I sometimes have to have help getting out of bed. So she helped me out of bed, and we went to the mirror, but I really couldn't see back here. I could just feel. Um, Saturday, that was um, Christmas Day, but then Saturday morning, like I said, when I woke up, it was just covered the right side of my face. Sunday,
Can you describe what it looked like a little more in the mirror? What you saw?
um, if you've ever had sunburn and your skin got moist and the little bubbles appeared, some of them ran together, some didn't. They were all different sizes and whatnot. That's what the shingles look like. I didn't feel any pain, severe pain, until that following Tuesday. But by that time, I went to my dermatologist, told him what I'd read online, and yeah, because I don't want to look at that again.
Yes.
um, Told him what I read online, and he came back and he said, yes, he said, you have shingles. First, I wanted to know, how did I get it? Is it something that's passed down from generation to generation? And the answer was no. Um, I had a, oh, I'm sorry. I had a prescription filled by Dr. Lokshin. Within, I say, 5 days, the blisters was clearing up. Um, the pain lasted from Tuesday to Friday, and the pain was so severe, all I could do was sit on side the bed and just cry. Cold compress doesn't help. Warm compress doesn't help. The fact that you put your hand up here, it doesn't hurt, but it doesn't help. The pain was like under the skin. Um, and you just had to wait it out. I found out that I was in a contagious stage, which really concerned me because I work for a defense company, so I'm around people all the time. Christmas Day, I was with all of my little family members that I hadn't seen in a long time, so I thought that I was going to give it to them. Um, and it was not a really good feeling to think that you gave your kids, some kind of disease. But I called all the parents. The kids either had chickenpox or they've had the chickenpox vaccine because
Mhm.
that's required now in Montgomery County Public Schools. So I was fine. But then on my job, I gave a list of all the names of the people that I had talked to. Our building service person called the safety manager, told him what was happening because they thought they were going to have to scrub down my desk area. And he asked, did any of my blisters pop? And no, they did not. And he said that was the only way that I could pass the shingles off to someone else is if my blisters popped and the liquid got on a person. And then they would end up having shingles. Um, I feel fortunate because my pain was only 4 days, and I've been hearing some people's pain lasts for a month, 2 months, 3 months, and they have the blisters, the redness. You just don't feel good. And there's nothing you can do about it without the medication. And while I was taking the medication, I just had to deal with the pain. And the only thing I could do was cry. I mean,
Sandra, can you describe the character of the pain a little bit more? Was it
in
dull,
between,
sharp?
um, not really sharp. I've compared it with a really bad toothache or childbirth.
Okay.
It is bad. It hurts. And like I said, you can't do anything about it. The medication takes a couple days to get in your system. Other than that, you just deal with it. You either pull your hair out, or I don't recommend suicide or anything like that, but cry. That was
Did you have any itching associated with it at all?
not until after the blisters had kind of dried up, and the only itching I had was the blisters that was in my hair
Hmm.
because this side of my head, it was like 3, 4 rows of blisters that went
Mhm.
all the way down. So I had to use my fingers to comb this side of my hair.
Mhm.
Um,
Did you have any blisters on the other side of your head?
nope, just the one side.
Okay.
And I was surprised when I found out that I had shingles, that it was on my face. But I did find out that a lot of medication can bring out the shingles virus, and stress. And I was under both. So I don't know which one brought the shingles on. Um,
You don't have to tell me what it was, but were you on taking medication that suppressed your immune system at the time?
um, I think yeah, I think it was. I mean, I was hurting so bad. I didn't ask Dr. Longshan a whole lot of questions. It's
Mhm.
like, give me the drugs so I can start taking them now to get rid of this pain, because the pain is that severe.
Mhm.
Now, I don't know how strong minded people are and whatnot, but if you ever get shingles, and I don't care how old you are, do not be alone. Just don't be alone. It's somebody you can yell at, you can cry with, but just don't be alone, because it will set you crazy, because you can't do anything about the pain except wait.
What did your doctor treat you with?
Pills, medication,
What
3 times a day. I have it in my bag. I couldn't pronounce it
is
for you.
something called Valtrex or Valacyclovir?
Yes. Spell it. VALVC.
Well, the trade name is Valtrex, Valtrex, and the generic is Valacyclovir,
All right. Right. That's what I had, the generic
Valacyclovir.
brand.
Good.
But it works.
Did you take anything for pain?
Um, no. I mean, at first I took some Tylenol because of the medication I'm on. Extra strength Tylenol is the only thing I can have. No, it was waste. It was just a waste.
So extra strength Tylenol, the
No,
500
didn't.
milligrams,
No,
didn't touch it.
no, didn't help at all. You didn't even know you took Tylenol. That's just how great the pain is. And like I said, it felt like, to me, the only way I can describe it is the pain was under the skin. So anything you did on the surface, it wasn't going to work.
Did your doctor offer you any other types of medication for pain?
Um, no, and I really didn't ask. I just um, I just took it for 4 days.
Okay. Sounds like you had a very challenging time there. I'm so glad you're better.
But I still feel like I'm fortunate because people have it for months, and I was
That's
just,
right.
yeah, I was like
That's
that
right.
for just a week.
We'll talk about that a little more. So would you mind answering
No,
questions
I don't
from the
mind.
audience if they have any? Does anybody have questions for Sandra?
Yes, as a child. And I did not think that I would get shingles. Been hearing about it, reading about it, there's commercials on TV. It just never registered. And one of the reasons why I'm here today, let it register in everybody's mind now. If you had the chicken pox, get the if you're consult your doctor. But if you've had the chicken pox, get the vaccine. If My daughter is 24, I had her go to her doctor at 24, and she had a mild case of chickenpox, 6 all over her face, and that was it. Her temperature was 100. If it got that high, her doctor said no. She wasn't concerned. If I was to let her go ahead and get the vaccine, but if the doctor wasn't concerned at 24 that she should get the vaccine, um, and get the vaccine, uh, then I wasn't either. But I have a doctor's appointment in March with my dermatologist, and I want to make sure that my system is clear of shingles, because I am going to get the shingles vaccine. I understand that I can get shingles 2 more times.
So we'll talk more about that, Sandra. Well, our goal is to help everybody understand how shingles happens and can it happen again? Who should get the vaccine? So that's all in our talk. I hope you can stay and um, listen to us. Um, any questions before we finish?
Okay.
Okay.
Well,
Thank you
for
so
your
much for
input.
sharing your story. Thank you.
Maybe I should let you professional do it here. Okay, we're going to divide the talk here into two parts. I'm going to be talking a little bit about what shingles is and the immune response to shingles, and then Dr. Dropulich will tell us about how we treat shingles and how we try to prevent shingles. So the virus that causes shingles is called the varicella-zoster virus. You heard from Wynn. And this is a virus that causes us to get chickenpox or varicella, usually when we're very young. And you can see here a young child here who has a disseminated rash, and this rash is from the varicella-zoster virus. The virus actually infects the oropharynx, the mouth, and infects the lymphocytes that are at the T cells, particularly CD4 cells, and the CD4 cells travel throughout the body. They can travel to the skin, and you can get a rash. They can travel to different organs, and they can also travel to the nervous system. And when the nervous system becomes infected with the virus stays in the nervous system for your entire life. So if anybody in the audience have had chickenpox, you have the shingles virus in you, and that virus can reactivate as you get older, as we'll hear about. So when the virus reactivates, one gets a rash, and the rash, as you heard from Wynn, can frequently be sort of a belt-like rash around the thorax, shown here. And the rash itself, if you look on the bottom there, looks just like the rash of chickenpox. But unlike the rash of chickenpox, it's defined in just what's called a dermatome, innervated by a nerve, as opposed to chickenpox, which is spread throughout the entire skin. So this slide just shows, again, during the chickenpox, the virus can spread in the blood and infect what's called the dorsal root ganglia, which are alongside the spine. And each of the dorsal root ganglia will innervate a different part of the skin. The virus can also infect the skin, shown here, and it can travel up the nerve and also infect the dorsal root ganglia. But this is the site where the virus is dormant or latent for the rest of your life. And if you're unlucky, the virus can reactivate from the dorsal root ganglia, come down the nerve, and then cause the rash of zoster. And again, the rash is localized to the individual dorsal root ganglia where it reactivated. So it's usually just a patch of skin. And there are dorsal root ganglia on each side of the spine. And so one typically gets a rash just on one side of the body, not on both sides of the body. And that's a very important distinguishing factor for the doctor to know that it's shingles and not something else. Now, several years ago in our laboratory, we looked at ganglia from individuals who died for other reasons, and there were actually 10 individuals who died, some just from old age. Kenning Wang in my laboratory took out the dorsal root ganglia, and here's a slide of a cross-section of one of the ganglia. And you can see these round things here, which are actually individual neurons, and that's where the virus is latent. And using a system called laser capture microdissection, you can pluck out individual neurons and put them on a slide. And you can see here, this neuron is no longer gone, is now gone because it's been put on a separate slide. And then you can take these individual neurons and by a process of PCR, determine whether there's the shingles virus, varicella-zoster virus, in those neurons. And you can see poor Kenning had to look at over 1,700 neurons in this study before we let her finish the study. And you can see that approximately 4% of the neurons had varicella-zoster virus in them. And the average neuron that had varicella-zoster virus in it had about 7 copies of the virus in each neuron. So we can actually look and see, again, how many neurons are infected and what the copy number per neuron is. So again, you heard from Wynn, the history of zoster gets its name from Gödel, both in Greek as well as in Latin. And this is sort of a typical rash here. And the virus was first actually seen on March 19, 1949. We heard that Tom Weller was the one who actually identified the virus. And he took cultured cells, took fluid from a blister, or we call a vesicle fluid, put it onto these cultured cells, and then stained the cells. And what you can see here are individual cells, and these blue areas are the nucleus of the cell. And in almost all the nucleus, you see this red area, which is what's called an inclusion body. And this is with the neurons here. The inclusions stain red. So each one of these cells has virus in it here. And so in his lab notebook on March 19th, he noted that he had found effects corresponding to the shingles or varicella zoster virus. And as you heard, he went on to work with on other groups, other individuals in his group growing polio, and won the Nobel Prize really for polio. So this is an electron micrograph of what the varicella zoster virus looks like. You see a nucleocapsid, which is a protein that encodes the DNA, protects it. And then there's an envelope around it. And then there are these spikes, which have viral glycoproteins on them, and that's how the virus attaches to your cells. So about 99% of us who are over age 40 have been infected with varicella zoster virus, which means we're all at risk for developing shingles. Each year, there are about 1 million cases of shingles in the United States. And unfortunately, the rate of shingles seems to be increasing. We can talk about that later if there are questions about that. But about 50% of us, if we live to age 85, will develop shingles. And about 5% of us can actually get a second case of shingles. So it really affects a large portion of the population. The major risk factors for getting shingles are age. And the older you are, the more likely you are to get shingles. And part of that's because it's been a long time since you had chickenpox. It's a long time since your immune system has seen the virus. And your immune system can no longer recognize the virus as well as we get older. So the longer you are since you had your episode of varicella or chickenpox, the more likely you are to get shingles. And individuals who are immune compromised, particularly those who have impaired what's called T-cell immunity, not people who have low levels of antibodies, but low levels of T-cells, like transplant recipients, people with leukemia, lymphoma, who are on immunosuppressant medicines, or HIV patients, those individuals are also more likely to get shingles. Again, their immunity to varicella zoster virus, their T-cell immunity wanes. So again, age and immunocompromised reduce T-cell immunity and allow the virus to reactivate. So as I mentioned, the virus can be latent or dormant in the dorsal root ganglia, which are alongside the spine, can reactivate along the nerve, and then result in a rash on the chest or in the abdomen. The virus can also be latent in what's called the trigeminal ganglia here, which it was likely in our patient today, or in the facial nerve here. And again, the virus can reactivate on the face. So it turns out that, again, the dorsal root ganglia are alongside the spine, and they innervate individual portions of the skin. And one of the ways these dermatomes were mapped by Henry Head many, many years ago was by seeing patients with shingles and noticing that the rash was in a certain area here, and he surmised that that's where the dorsal root ganglia must be because the virus is reactivating from that. So it was a way actually to map the anatomy of the human body, which I thought was quite interesting. So just an example, here's a woman who has a rash on her upper back here, and it's actually in the dermatomes by the T1 and T2 thoracic dermatomes. Here's another woman who has a rash a little bit higher up as well as on her arm, and you can see that corresponds to the C5 and C6 dermatomes. And a gentleman with a rash on his face. You can see it's the left side of his forehead, the left side of his nose, and involving the eye, again, on the V1 distribution of the trigeminal nerve. So as we heard today, the rash is often in what's called a dermatome. It does not cross the midline. It's just on one side of the body. Individuals can have a few lesions outside the dermatome. And the rash usually continues. New lesions pop up for maybe 5 days to a week. These rashes start off as just bumps. They eventually become fluid-filled bumps, which are vesicles, and then inflammatory cells get in there, so you have what are called pustules, pus inside those areas. And then eventually they break down and they crust over and they heal up. And it usually takes about 10 days to crust over and maybe 2 weeks for the rash to really resolve. Interestingly enough, some patients actually don't get a rash. They'll just have pain in the area, and that's called zoster sine herpetae, and it can be a very difficult diagnosis for the doctor to make. Now, in addition to the rash, what many of people fear is really the pain associated with shingles. Typically, before the rash occurs, as you heard today, a person can have a change in sensation, like itching, tingling in that area. And that can make it very difficult to tell that it's really due to shingles. In fact, some patients have had a lot of pain in the area, have gone into the hospital, and have been misdiagnosed as having abdominal pain, chest pain, a heart attack. And then as they're in the hospital, suddenly a rash erupts in that area, and then the doctor realizes, no, it's not a heart attack, it's actually just shingles causing abdominal pain or causing chest pain. And the pain can range from just aching pain or burning pain, stabbing pain, excruciating. Some patients have it continuously, some patients have it episodically. And up to 10% of patients won't have any pain, particularly younger individuals. The older you are, the more likely you are to have pain with that rash. And the pain can last for different periods of time. This was a study done in individuals about 56 years old on mean, and you can see at 1 month, for instance, about 55% of them had pain still, and about 25% had clinically significant pain, 5% had severe pain. But unfortunately, many of these individuals had residual pain even after the rash had resolved. And for clinical studies, we say that an individual that has a rash, that has pain lasting longer than 3 months after the onset of the rash has a disease called postherpetic neuralgia. So again, even after the rash resolves, individuals can have this pain. So postherpetic neuralgia, pain can persist for months or even years. It's thought to be due to nerve damage caused by the shingles virus. And the nerve damage can be the nerves that are involved in the skin, or the nerves actually going even to the spinal cord. More common in the older you are, and people can have very different kinds of pain with that postherpetic neuralgia. Some people say that just clothes touching your skin can cause just agonizing pain, or a breeze on your cheek can cause just severe pain. That's called allodynia, a non-painful stimulus causing pain. People can have paresthesias with burning or tingling, impaired sensation, or continuous neuropathic pain. And it really can be quite severe. So how does zoster, or how does postherpetic neuralgia affect people's lives? Well, it can, people can have fatigue, weight loss, loss of appetite, physical activity. People can have difficulty sleeping at night, anxiety, depression, suicidal ideation. They can become very introverted and stop interacting with people, and it can really be very traumatic and really make people's lives miserable. My father actually was a very active working person, developed shingles and postherpetic neuralgia. He had pain for over a year and didn't sleep almost for over a year, and he subsequently retired. But the pain after over a year finally relented. But it was just, he said he wouldn't wish it on his worst enemy. So again, the risk factors for postherpetic neuralgia: the older you are, the more likely shingles can develop into postherpetic neuralgia. It's rare in individuals under 40. And for individuals who have the most severe pain or the most severe rash, that's probably associated with the most nerve damage, and those are the individuals that are highest risk for getting postherpetic neuralgia. Interestingly, immune compromise is not really a risk for postherpetic neuralgia. It is for shingles. So postherpetic neuralgia, there's 100,000 to 200,000 cases per year. About 10% of zoster patients will have a pain that lasts more than 90 days. 20% will have pain lasting more than 30 days. And here, this shows the rates of both zoster, shown in gray here, and postherpetic neuralgia. And the take-home lesson, again, is the older you are, the more likely you are to get shingles, and the more likely your shingles is to result in postherpetic neuralgia. So there are a number of neurologic complications of zoster. People can have what's called Bell's palsy, where you have drooping of the side of the face, unilateral facial paralysis, and that's due to reactivation of the virus in one of the cranial nerves. If the virus reactivates in a different area of the cranial nerve called the geniculate ganglia, you can have vesicles in your ear with numbness of the tongue, again, weakness of the facial muscles. Oftentimes these do resolve over time, but it can be really miserable when you have it. Another cranial nerve can be involved, and you can have hearing impairment. People can have meningitis, Guillain-Barré, which is a form of weakness you may have heard associated with Zika virus, but also with zoster, and disease involving the spine with paralysis known as transverse myelitis. If the virus infects the cranial nerves, if the virus infects the cranial arteries, it can cause an inflammation or what's called a vasculitis, and these arteries can become very narrowed such that blood can't flow through and people can have a stroke or what's called a transient ischemic attack, where one has sort of almost like a temporary stroke that just lasts for a few minutes to hours and then reverses. But it can be a very severe disease as a cause of stroke even. And then eye complications are also seen in patients with zoster, particularly people who have a rash in what's mentioned in the V1 distribution involving the side or the tip of the nose. And really any part of the eye can be involved. 15% of individuals will get, with zoster, can have zoster involving the eye. It can affect the cornea, the surface of the eye. It can affect the interior of the eye, the uveitis. It can affect the retina that we use for vision. And it can also cause glaucoma. And several years ago, I saw a person who presented with problems with vision. He'd seen his doctor, and the doctor said, "Don't worry about it. I recommend you go to an ophthalmologist." And he actually had so much inflammation of the eye that it was blocking the path of fluid in his eye, increased pressure in his eye, and he had to be treated for glaucoma. Otherwise, he would have lost vision in the eye. So it's very important if one has eye involvement to see their eye doctor, because there are sometimes specialized treatments that an eye doctor will provide. Other complications, the rash can become infected with bacteria. People can have a lot of itching even after the rash is gone. About 3% of patients with zoster are hospitalized, usually either for the neurologic complications or for the ocular complications. And as we heard today, the virus can be transmitted to susceptible children. If you've had the chickenpox vaccine or the chickenpox, you shouldn't get zoster from someone. But if there's an infant that's never seen the virus, they can get it from shingles. Again, the virus is less transmissible from somebody with shingles, about 1/5 as transmissible as somebody who has varicella or chickenpox. Now, this is what I've mentioned before. It's what happens in people who have a normal immune system. But unfortunately, we sometimes see individuals who've had a bone marrow transplant, a patient who has HIV or something like that, and those people can have even a worse case with shingles. And in those individuals, when the virus reactivates, instead of just going along the nerve, the virus can reactivate in the blood, and one can get virus in the blood or viremia. And instead of getting just a rash that's localized to one sort of strip on the body, those individuals can get a disseminated rash that looks identical to chickenpox. Again, the virus is spread in the blood, just like it does during chickenpox, and those individuals can get very ill and die from zoster. Those individuals frequently have lesions that form for many weeks, much longer than you would in a normal host. Healing can take longer. They can get this generalized rash, but they're more likely also to get complications with viral pneumonia, virus infecting the liver with hepatitis, virus in the brain, and encephalitis. So it's those patients where it's very important for them to get medical care and to get treatment. We've seen patients here with HIV. This was a patient I saw a number of years ago who had this warty-like eruption that really looks like warts, but when this was biopsied, there was varicella zoster virus in the tissue here, and it was an unusual rash associated with zoster. Patients with HIV can get necrosis of the retina, and they can actually get chronic zoster, which doesn't really go away, it just persists despite therapy. We've also seen bone marrow transplant or stem cell transplant patients that will reactivate internally in the celiac ganglia, which innervates the GI tract. Those individuals can get inflammation of the pancreas and abdominal pain, And I remember distinctly the first month I was here at NIH, and I saw a patient in the intensive care unit who had abdominal pain, no rash at all. And the way it was diagnosed, unfortunately, was the nurse that took care of the patient who'd never had chickenpox became infected with chickenpox. So this is very difficult to diagnose, and if it's not diagnosed, particularly in an immunocompromised patient, it can be fatal. Nowadays, we can sample the blood in these patients and detect virus in the blood. This was an HIV patient I saw a number of years ago, and you can see there's a lesion in the eye here due to varicella zoster virus, and the patient also had lesions in the brain due to the virus. So again, these immunocompromised patients can be very ill. So the immunology of zoster, zoster patients turn out to have normal levels of antibody to varicella zoster virus usually, but they have reduced T-cell immunity. And again, the zoster is due to weakening or reduction of the virus-specific T-cell immunity, not due to a lack of antibodies. So over time, as we age, if we look at the cellular response to varicella zoster virus, either by a skin test, in which a doctor can put varicella zoster virus antigen on the skin, just like we do with a TB, look for TB, a PPD, or you can take out blood and look at lymphocytes that proliferate in response to the virus. As we age, the cellular immunity to the virus goes down, and that means we're more susceptible to reactivation, more susceptible to zoster. And the model that's been proposed is, if you look here, this is the level of cellular immunity to varicella zoster virus. An individual becomes infected with chickenpox, and the immune system respond to the chickenpox. The T cells increase that are specific for varicella zoster virus increase in number. They can wax and wane over time. If one gets exposed to a child with varicella, which is less common now that we have a varicella vaccine, the T cell responses can increase. Again, over time, the body hasn't seen varicella, the cellular response goes down. You can have subclinical reactivations where you don't get the shingles, but the immune system can sort of gets boosted and see the virus. But eventually, as we age, many of us, the cellular immunity will go below a certain threshold, and the virus will reactivate, and we will get shingles, and this will result in symptoms. And what you'll hear Dr. Dropulich mention is that we have a vaccine now which, like zoster, can boost the immune system and reset the immune system. And the idea is that the shingles vaccine can reset the immune system so that you're less likely to get shingles. So finally, the diagnosis of zoster. Usually the doctor does not need to do any blood tests, usually just by looking at the patient. If they have a typical rash that is only on one side of the body, it's usually localized to 1 or 2 dermatomes associated with pain. That's enough to make a diagnosis of zoster. There's some patients, however, who may not get a rash, may have an atypical case, and what you can do is scrape the lesions. You can take that little bit of fluid that's in there and do what's called a PCR reaction and detect viral DNA in the skin fluid. Or if one has a person with bad central nervous system disease, one can do a spinal tap, take the spinal fluid, and do PCR for VZV. And Dr. Dropulich and I often are frequently consulted for individuals who've had, quote, recurrent zoster, multiple episodes of zoster. And most of these patients actually don't have recurrent episodes of zoster. They have recurrent episodes of herpes simplex virus, which can masquerade and look like zoster. These individuals have frequent recurrences. As I mentioned, most people will only have 1 case of zoster in their lifetime. So I think what we'll do is move on to how we treat and how we prevent zoster, and we'll have Dr. Dropulich tell us about that, and then we'll open it up for questions. Which one are you here? Is that you? Nope, that's Wayne. Sorry. No, maybe there. I'm not sure.
Here.
Yep.
Thank you. Okay, so let's
Just
see
go
what
down
we
with
can learn
time.
about the treatment and prevention
Just
of
worried about
shingles.
time.
So I'm not the investigator of the zoster, was an investigator in the shingles vaccine trial, but in our laboratory we do study herpes virus vaccines, and currently we have a herpes simplex virus 2 vaccine trial that's ongoing, a phase 1. So the goals of antiviral therapy for herpes zoster is to decrease the severity and duration of pain caused by the acute neuritis. So this is the inflammation caused by the virus that's transversing down from the sensory dorsal root ganglion down to the skin. So that inflammation of that nerve where the virus is replicating is causing a lot of pain. To promote more rapid healing of the skin lesions, to prevent new lesions from forming, and also to decrease viral shedding so that we reduce the possibility of transmitting this infection. The FDA has approved 3 antiviral medications specifically for the treatment of herpes zoster, and those are acyclovir, valacyclovir, and famciclovir. And these have been shown to be effective in clinical trials. They're quite well tolerated. They differ in terms of their bioavailability. The older drug here is the acyclovir, whose bioavailability is poorer. Hence, we have to give the drug more frequently, 5 times daily. But these have been replaced by newer medications like valacyclovir, which is very well absorbed and gives 3 to 5 times higher level of antiviral drug activity of acyclovir. It's a prodrug of acyclovir, and it's only administered 3 times daily. And then there is famciclovir, which is a prodrug of penciclovir. And these drugs are quite well tolerated. The most common side effect with acyclovir is malaise. Not everybody will get these, obviously. And with Valtrex and Famvir, it's nausea and headache. There is clinical trial evidence for the efficacy of these antivirals. They do indeed hasten the resolution of lesions. They reduce formation of new lesions. They reduce viral shedding, and they also decrease the severity of the acute pain. However, there's no evidence that they reduce the incidence of postherpetic neuralgia, which is probably the most debilitating complication of shingles. As you heard from our patient, she couldn't take, for some reason, medications other than acetaminophen, but she was very happy to be taking what sounds like valacyclovir. Patients most likely to benefit from antiviral therapy for herpes zoster are those people who are 50 years of older, and that's because they have more severe disease. Patients with moderate to severe pain at the onset of shingles, patients with a severe rash with large numbers of lesions, and patients whose face or eyes are involved or who have other complications. So to prevent complications, we use antiviral therapy in these patients. And as Dr. Cohen showed, in the immunocompromised patients who can have very severe debilitated disease of various organs, including the central nervous system, we definitely use antiviral therapy in these patients. And usually in immunocompromised hosts, we rely on the intravenous administration of acyclovir in order to get sustained levels of drug, sustained activity to most effectively treat their severe infection. With acyclovir, we have to be cautious, with the major side effect being renal insufficiency, but if it's administered slowly over 1 to 2 hours, we don't usually encounter this complication. And the other medication we use alternatively for acyclovir-resistant varicella zoster virus, which we don't encounter usually in the normal host, but we do encounter in these immunocompromised hosts, that is not FDA approved. It has much more significant side effects, including renal insufficiency, various electrolyte abnormalities, GI side effects, gastrointestinal side effects, as well as effects on the bone marrow, such as anemia and decreased white cell count, granulocytopenia. So the challenges when somebody presents with shingles is to treat their pain. So we have the antivirals, which are quite effective, but more challenging, I think, is using these medications to get their acute pain under control, and especially pain that is derived from the nervous system being affected can be very challenging. And what experts usually recommend is when somebody has mild pain to use non-opioid analgesics, and these would be things like acetaminophen or trade name Tylenol, or non-steroidal anti-inflammatory agents like ibuprofen or Motrin or naproxen. If the pain is a little bit more severe, one can add or independently use mild opioid analgesics, not as strong, I should say weaker, codeine or tramadol. However, if the pain is more severe, then one may have to use drugs, medications like oxycodone. So one needs to base this on what the patient, how the patient feels, how severe their pain is, and it's a subjective thing, but our goal is to alleviate symptoms so the patient is comfortable. And secondly, if the symptoms are not responding to these analgesics, we employ other medications, for example, anticonvulsants such as gabapentin or pregabalin, which have actually been FDA approved for the treatment of neuropathic pain and can be quite effective in this circumstance, as well as antidepressants, nortriptyline and dazipramine. So one can use a combination of these medications depending how the patient is responding. Prednisone, the corticosteroids, are more controversial. These should be avoided in patients who have certain conditions like diabetes, hypertension, osteoporosis, but that would require long-term treatment of corticosteroids to have an effect on that. So we always evaluate the entire medical history. We assess what medications the patient is already taking to determine what strategy may be employed in a particular patient. But especially in the elderly, use of corticosteroids has been associated with more severe side effects and secondary bacterial infections, so we try to avoid that. And lastly, some may obtain relief by using topical therapies such as a lidocaine patch, which should be applied on intact skin, not onto the rash, so in the region of the rash, but on intact skin. A little bit more about use of glucocorticoids with antiviral therapy for zoster. Randomized control studies, some of them have shown you get reduction in pain, accelerated healing, and improved performance of activities of daily living. However, there has been a meta-analysis that showed that it really, when they looked at 4 placebo-controlled trials, that they didn't find that these outcomes were indeed true. Studies have not shown a reduction in the incidence of post-herpetic neuralgia. Rarely we do use them when we encounter a case of herpes, the vasculitis that Dr. Cohen described, or Bell's palsy, in order to concomitantly, along with the antiviral treatment, treat these infections in the central nervous system in order to, at the same time, decrease the inflammation and decrease complications and symptoms. And I mentioned already about avoiding use of steroids in patients who are subject to complications from use of steroids. Treatment of post-herpetic neuralgia can be quite challenging. As you heard, patients can have pain for a prolonged period of time, and this is neuropathic pain, which is notoriously difficult to treat. And listed here are medications that have been approved for the treatment of post-herpetic neuralgia, namely the anticonvulsives and tricyclic antidepressants have been actually approved for neuropathic type pain and are commonly employed to try to provide some relief to these patients of this debilitating complication of zoster. And they can be used independently, so often experts recommend starting with the tricyclic antidepressants initially and then progressing if that doesn't work, or perhaps adding the anticonvulsants on board. And the third line of possible treatment, we reserve that later to opioids because of the concerns for addiction. So this comes up later in the armamentarium. And also on this list are topical therapies like lidocaine and capsaicin. Once again, the lidocaine needs to be applied to intact skin. The capsaicin is tricky because it has to be applied several times a day for 90 minutes and taken off. And people complain of the burning sensation and redness on the skin. So it's a difficult treatment to follow sometimes. And because it is so challenging, often we seek the assistance of pain specialists when we have a patient who has postherpetic neuralgia, who use the standardized approach for treating chronic pain in these patients. So now on to vaccines that have been developed for the varicella-zoster virus. You are probably all familiar by now, and I'm sure many of you in this audience may have received the varicella vaccine, which is also called VariVax, and it was approved by the FDA in 1995 for the prevention of chickenpox in persons who are greater than or equal to 12 months of age. And the zoster vaccine, Zostavax, which I'll tell you about the trial in a moment, was approved by the FDA in 2006 to prevent shingles in persons who are greater than or equal to 60 years of age. The varicella vaccine, also known as the Oka vaccine, was developed by, in Japan as a live virus, a live attenuated virus in cell culture. And the zoster vaccine is identical to this virus. However, it has a 14-fold higher titer than the varicella vaccine. And that's because people who are receiving it are immune. They've had chickenpox. So in order to be effective, the designers of this vaccine determined that it needs to have a higher concentration given the presence of the immunity, vis-a-vis specific immunity. In 2008, the CDC recommended routine vaccination among people aged greater than 60. The shingles prevention studies was a huge study, a randomized, double-blind, placebo-controlled trial of 38,546 adults who were 60 years of age or older. So it was a very large multi-center trial. Just an example of what it takes to test a vaccine and take it to market. The hypothesis was that the live attenuated Oka Merck vaccine was developed by Merck, would decrease the incidence and severity of herpes zoster and or of postherpetic neuralgia. And then inclusion criteria for the study were that you had to be 60 years of age or older. The mean age was 69 with a range of 59 to 99. And you've had to have a history of varicella, chickenpox, or if you could not provide documentation of that, you would have had to live in the United States for 30 or more years, because studies have shown that the majority of those patients have had chickenpox. So these people were all had vis-a-vis specific immunity. Exclusion criteria were that you already had a history of shingles, that you were immunocompromised. They didn't want to administer it to anybody who was immunocompromised, since it's a live attenuated vaccine. And they also excluded people who had conditions where they could estimate that their life expectancy was less than 5 years. The primary endpoint of the shingles prevention study was the burden of illness. And this was a composite of the severity of the zoster and the duration of pain caused by herpes zoster. And this was first assessed, this was assessed for each individual participant, but then a composite burden of illness was the primary endpoint that was analyzed by the statisticians. And the secondary endpoint was postherpetic neuralgia, and it was defined as pain or discomfort with a pain score of greater than 3 out of 10, at a scale of 10, that persisted or appeared more than 90 days after the onset of herpes zoster rash. So these all endpoints are very important in the clinical trial, and it's all predetermined so that the results that are obtained are valid. So in the shingle prevention study revealed that compared to placebo, the zoster vaccine reduced the burden of illness by about 60%. This was significant. The incidence of post-herpetic neuralgia by 66.5%, and the incidence of herpes zoster by 51%, which actually was a tertiary objective. So primary objective of burden of illness, and secondary objective of post-herpetic neuralgia. The vaccine was well tolerated and had mild injection site reactions compared to placebo. Looking at this a little differently, in a paper that followed the vaccine study that was originally published in the New England Journal in 2005, the vaccine reduced the burden of illness, as I said on the prior slide, in all subjects. 61.1% efficacy was the efficacy of the vaccine. However, if you look at the different groups, age 60 to 69, this efficacy was maintained. However, in participants who were 70 years of age or older, they saw a decreased efficacy of 55.4%. So that was the primary endpoint. When you look at the incidence of zoster, the efficacy of the vaccine efficacy in preventing the incidence of zoster also was found to be decreased in the 70 or greater age group. However, the vaccine efficacy for post-herpetic neuralgia remained unchanged compared to the 60 to 69 group and the overall, looking at the overall subjects. So this was an important finding, despite its efficacy against the incidence of zoster not being maintained and the burden of illness not being maintained. Given that this is such a potential significant complication in the elderly population, which causes a lot of morbidity, it was very encouraging to see that this vaccine held up in the older age patients. And looking at the details of the pain in persons with zoster, in those who've received the vaccine and those who received the placebo, the median duration of pain in persons who developed zoster was shorter in the vaccine recipients at 21 days than those who received placebo at 24 days. And this was significant with a p-value of 0.03. The degree of pain was also less in the vaccine recipients and the placebo recipients compared to the placebo recipients. And looking at time to event, Dr. Oxman was the first author of the shingles prevention study. So time to event of the incidence of post-herpetic neuralgia out to 4 years. Those who received the zoster vaccine, you could see that it remained effective out to 4 years. And then the cumulative incidence of herpes zoster, shingles, also the vaccine efficacy was maintained out to 4 years. So after this trial was completed, the indications for the zoster vaccine, Zostavax, were that this is indicated in all persons, well, actually, there are some contraindications, all persons who are 60 years of age or older, but it was contraindicated in persons with hematologic malignancies, but it could be given in patients who are in remission and had not received any chemotherapy or radiation therapy for 3 or more months. It was contraindicated in patients with AIDS or HIV infection with very low T cell counts, CD4 T cell counts, also contraindicated people who've had bone marrow transplants or other causes of T cell deficiency. And that is because these patients are susceptible to severe disease that Dr. Cohen described. Patients who are on high-dose immunosuppressive therapy, daily prednisone at more than 20 milligrams a day, treatment, various biologic therapies like anti-tumor necrosis factor. The recommendation is to wait for 1 month after stopping these treatments to vaccinate. And people who are allergic to vaccine components, neomycin and gelatin, this vaccine was also contraindicated in these persons. So in summary, the zoster vaccine maintains its efficacy regardless of the age of subject. And in the younger patients, these are the 60 to 69-year-olds, it is mediated mostly by preventing zoster. So these younger folks don't have as big of a problem with post-herpetic neuralgia and other complications. And so primarily, the efficacy of the vaccine is seen by preventing shingles. However, in the older participants who are 70 years or more, as you saw, we lose the efficacy for preventing zoster, but we maintain the efficacy for preventing post-herpetic neuralgia. And this is a supplementary study done by using the the participants in the shingles prevention study. And what we're seeing here is we are seeing vaccine recipients who did not develop shingles, but were vaccinated, and placebo recipients who didn't get the vaccine but developed zoster. And what we're comparing in these two top panels is these were two different T cell assays that were conducted. And you can see that at 1 year, 2 year, and 3 year after vaccination, that the T cell responses were vis-a-vis specific T cell responses to was similar in the recipients who received the vaccine and those who developed natural infection, shingles. So this is important because, as Dr. Cohen pointed out, it's these vis-a-vis specific T cell responses that are important for preventing us from getting shingles in the first place, showing that the vaccine effectively elicits these immune responses. So the question came up, what about younger folks? Should younger folks who are the next decade down, 50 to 59 years, be vaccinated? And there was a study done, which was a randomized trial called ZEST, Zostavax Efficacy and Safety Trial, which evaluated the safety and efficacy of vaccine, again, in many, many subjects, 22,439 subjects who were aged 50 to 59 years. And they were randomized and given a single dose of the Zostavax vaccine or placebo. And they were monitored for the occurrence of shingles for about 1.3 years after vaccination. And they found that indeed the vaccine, the zoster vaccine, was quite efficacious in this 50 to 59-year-old group at 69.8% in preventing shingles. After this, the FDA approved the use of Zostavax vaccine in the 50 to 59-year-olds. However, the Advisory Committee on Immunization Practices is not recommending this at the current time. And probably the main reason for this is that they think if you give the vaccine this early to participants, then they may develop waning immunity down the road. I'll show you some evidence that will reveal that that's probably happening. And then they won't have vaccine, they won't have the advantage of having been vaccinated 10 years down the road, and then they'll have to be boosted again. So they wanted to see what was the long-term persistence of the zoster vaccine efficacy. And so the shingles prevention study evaluated efficacy up to 4 years after the participants were given the vaccine. And this assessed vaccine efficacy of these participants, a sub-study of these participants, almost 7,000 of them, up to 11 years post-vaccination. So compared to the shingles prevention study, which you saw that vaccine efficacy was maintained up to 4 years. For years 7 to 11 post-vaccination, the vaccine efficacy decreased was found to decrease in these patients from 61.1% at year 4 to 37.3% at year 11 for the burden of illness, a herpes zoster burden of illness primary endpoint. Also, the vaccine efficacy for the incidence of postherpetic neuralgia decreased from 66.5 to 35.4% at year 11. And for the incidence of herpes zoster, it decreased from 51.3 to 21.1. So in sum, the vaccine efficacy persists for a burden of illness, persisted into year 10, whereas the vaccine efficacy for the incidence of zoster persisted only until year 8. So investigators have begun to study whether because of these results, whether a booster dose of the shingles vaccine should be administered to older adults who are 10 years or more after they were given the first dose of vaccine. So in this study that was recently reported, the second dose of zoster vaccine was administered to 200 participants who were 70 years of age or older. And this was compared to T-cell immune responses to participants who were vaccinated for the first time. So there was a group that was 70 or older. There was a group that was 60 to 69. I think there was a group that was 50, 59. And they found that for subjects who were greater than or equal to 70 years old, their VZV specific immune responses, and they looked at cytokines using ELISpot, interferon gamma, and IL-2 for VZV specific responses, was significantly higher at baseline and after vaccination in this group that was given the booster dose. And it was actually, the responses were actually comparable to participants in the 60 to 69-year-old age group. So hence, the booster dose was improved cellular immunity, but the effect on the incidence of zoster was not evaluated. So given that currently we do not have data on the vaccine efficacy for clinical endpoints, it cannot be FDA approved or recommended at this time. And new type, in addition to the live attenuated vaccine, which has been all the discussion so far, there's an adjuvant herpes zoster subunit vaccine that's being evaluated. And this is a vaccine that consists of a glycoprotein E and an adjuvant AS01B. And this vaccine is referred to HCSU. And the adjuvant is not FDA approved, so it's not known at this time what the long-term effects of this adjuvant are. However, investigators have studied this as a phase 3 randomized trial with a placebo. And they gave 2 intramuscular doses of vaccine or placebo for 2 months apart. And they followed these participants for 3.2 years. And what they found was that this subunit vaccine had a very high vaccine efficacy against the incidence of herpes zoster of 97.2% overall. And this vaccine efficacy was maintained in the older age group, the 70 or more age group, and was hence similar to the participants in their 50s and their participants in their 60s. So here is a table from the paper, and I point your attention to the column that shows the vaccine efficacy. There was a total vaccinated cohort and a modified vaccinated cohort. This modified vaccinated cohort consisted of people who only got 1 rather than 2 doses of the vaccine, and also participants who had shingles within the 30 days. Those people were excluded from this modified cohort. But you can see that the vaccine efficacy was 90%, over 90% in each of the different cohorts. In summary, antiviral agents have been shown to reduce the duration of lesions and the severity of disease, but not the incidence of postherpetic neuralgia. We definitely need new improved treatments for postherpetic neuralgia, or perhaps vaccines that may more effectively prevent postherpetic neuralgia. Herpes zoster vaccine is effective, but uptake has been suboptimal. About only 15% of people 60 years or older have gotten the herpes zoster vaccine. And this new subunit vaccine, which looks very promising given that it maintains its efficacy in the oldest age group, may have improved efficacy compared with the Zostavax vaccine and may be used in immunocompromised patients because it's not a live vaccine. And these vaccines are contraindicated in this group. And we've seen promising T cell responses in the booster doses, but still the efficacy and timing of these booster doses needs to be determined in further studies. Thank you.
Okay. Yeah. Thank you very much. We have some time. I hope there are some questions. Please speak into the microphone. Is this on? No.
So the question is about viral shedding and whether or not that's taken care of by the antivirals, or whether there is shedding outside the fluid in the blisters.
So there is virus in the blisters, and yes, the antivirals have been shown to decrease viral shedding. So
Is there shedding apart from the fluid in the blisters? That is it contagious even if you don't contact the fluid?
So in immunocompromised hosts, there's been rare incidents of airborne transmission of the virus. And yeah, it's rare, and it's more common, but still not common. In immunocompromised hosts, there's patients who present with disseminated infection, lesions everywhere. They have to be on isolation, contact isolation, as well as airborne isolation, because there have been reports of transmission of herpes zoster resulting in disseminated disease from these patients to other susceptible patients in hospitals.
And in chickenpox, the people can be infected from a person with chickenpox even before the rash of chickenpox occurs. So you don't necessarily have to have a rash present at the time for chickenpox.
I'm Naresh Chen from NIDA, and I'm just going to report a case of unusual side effect of the vaccine.
Keep it
And
short.
yes, just very short. I got the vaccination on January 2nd last year, and until now, this lower leg goes numb, pain, and other things, and it's not being repaired by medications, and I don't know what's cooking in my right leg.
Why don't you can discuss it afterwards with them about an individual case. I think it's a little complicated unless you want to comment.
Yeah.
No. Do any of the fellow students have questions about this? Could you pass this back, please?
Thank you. My question pertains more to like the multiple reoccurrences of zoster being mistaken, and it's actually the herpes simplex virus, which I was not familiar with before you mentioned it. I guess I don't really have a specific question about that, just if you could maybe provide more information about that. Like, I was unfamiliar with herpes simplex being able to appear outside of, oral versus.
So some people can get herpes simplex infection of the skin. For instance, wrestlers, it's called herpes gladiatorium, where wrestlers on a wrestling mat will have an abrasion of their skin. Herpes can get in there, can actually get again to the same dorsal root ganglia, and then it can reactivate on the same area of the skin. It's unusual. Most of us think herpes simplex is either oral herpes simplex, cold sores, or genital herpes. But if the virus does penetrate the skin, you have to break through the skin. It can affect the dorsal root ganglia and can reactivate. And again, when people had frequent recurrences, that's what we think about. If you just had one episode, it's much more likely to be shingles.
Go ahead.
So do we have one VZV more aggressive than the other, like different types of VZV, genetically speaking?
So there have been probably about 50 isolates that have been sequenced, but there's only a single serotype. There's really only sort of one VZV as far as we know. You can see sequence differences, and you can use that for epidemiologic studies, but it's really only one type of VZV. So we only need one vaccine, for instance, for VZV.
And do we have different, genetically speaking, people that are more prone to having a more aggressive form of shingles than others, and people that are more susceptible to having zoster in a earlier age, and or a more aggressive form of the disease, like uveitis or retinitis?
So people who have congenital T-cell immunodeficiencies, for instance, people with kids with SCID, severe combined immunodeficiency, or other genetic abnormalities that impair T-cell function, are more likely to get severe cases of zoster. People who have absent antibodies, agammaglobulinemia, don't necessarily have that. And there are people who with something called Job syndrome, who are more likely to get recurrent episodes of true zoster, for instance, than other people. But the common denominator here, again, is individuals with defective T-cell immunity.
All right, thank you.
So I have a question. What other diseases are associated with this recrudescence phenomena? In other words, a long period when after the acute disease, people feel fine, and then suddenly something happens and it flares up. What other diseases are associated with that? I mean, I can think of, I guess, hepatitis B is one, and maybe polyomavirus. Are there others?
So, I mean, there are a number of viruses. People get infected with the human papillomavirus, and then, there's a latency period when people can get, cervical carcinoma. Really, all of the latent viruses, that are latent some of them reactivate very quickly, as you mentioned, but other ones, hepatitis B, you'll get infected with it, and maybe 30 years, 40 years later, you could develop hepatitis B associated liver cancer. Same thing with hepatitis C, HTLV1. Many, many years later, one can develop this spastic paralysis and things. So there are a number of viruses that take a long time before they really result in disease.
So my question, coming from someone who had shingles probably way too early, got it like year after I started college, is psychological stress has sort of been shown as something that can either cause an immunosuppressive effect or at least change the way that the immune system works. Is that something that has been seen as a risk factor for getting a shingles attack? One. And two, being someone who is probably one of the last people who hadn't gotten shingles or varicella vaccine before it was mandated and had gotten chickenpox the standard way. What's the shortest time between incidence of chickenpox, latency, and then first attack of shingles that's happened?
So I know children, if you have chickenpox when you're a very small baby, like an infant, they have a higher chance of having shingles during their childhood. So we've evaluated people like that. I mean, I saw, I don't know, he was maybe 7 years old, and he presented with classic shingles on his chest. And, you know, we have studies where we look for underlying immunodeficiencies to try to determine if there's some predisposition to getting shingles. And the risk factor that has been noted in other studies is that if you have chickenpox when you're a very young child in infancy, then you have a higher chance of getting shingles very young. I don't know what the shortest time is between chickenpox and shingles.
We've seen immunocompromised patients who get chickenpox and then will get shingles really just a few years later. In terms of stress, you know, the evidence for stress as a cause of shingles is not great. I mean, there's anecdotes, and many people will say they had stress and they got shingles, but many people also have stress and don't get shingles. So I think people with severe stress, you know, the idea is if you have severe enough stress, whether it's going to depress your immune system and cause reactivation, but there's not a great correlation there.
Excuse me. Okay, but we have to repeat the question, please, because there are people who can't hear.
I think he wants to know the shortest time period between chickenpox and shingles. I don't know if anybody knows.
I don't.
Yeah, in the normal host.
I really don't know, but again, if you have an infant whose mother, for instance, gets chickenpox at the time of delivery, for instance, and the baby has no immune response, doesn't, you know, the antibodies won't transfer to the baby. Baby can get shingles, zoster. Excuse me. The baby can be born with chickenpox and get zoster really a few years later. I don't know the exact the world's record though. Maybe you have to look in the Guinness book.
Okay, go ahead.
Hi. Oh, Jeff.
Go ahead.
Okay, Dr. Burnell, who's a pediatrician here, said he knows of a case of zoster 3.5 months of age in an infant, mother who had chickenpox. Thank you.
Okay.
Hi, great talk. A couple of questions regarding the vaccines mentioned. First for the live attenuated VZV vaccine, is that thought to establish latency when it's administered? And then second question regarding the subunit vaccine that was in the phase 3 trial that you just showed. Are people evaluating the T cell responses to the subunit vaccine for the people who are vaccinated? And are there any sort of just general thoughts on how the correlates of protection against zoster might vary with age?
So the first question was, does the shingles vaccine establish latency? And it does, but not as effectively as wild type virus because it's attenuated and it doesn't reactivate as often. There have been very rare cases of vaccine-associated shingle-like rashes in actually the initial licensing study, the shingles prevention study, but subsequently there have been reports in the other trials of zoster-like rashes and chickenpox-like rashes, and they were all wild type. And then the second question was for the
type of immunity that the subunit vaccine that you mentioned, the most recent, the SU subunit vaccine, which is, you know, not the live attenuated. What type of immunity does that induce? So
actually, I don't remember.
So I think it's been shown to induce both antibody responses as well as varicella zoster virus-specific CD4 responses, not CD8s. Now, again, these people are primed, meaning they've been infected in the past, and you're getting a boost. But they've just again shown CD4 responses and antibody responses, and the correlate of protection for zoster is actually again T cell responses, be they CD4 or CD8, not antibody responses. So both a live attenuated, which would induce cellular immunity, as well as this vaccine, and particularly probably because of the adjuvant, you get a CD4 response.
I'm just wondering about the post-herpetic neuralgia. So I think you mentioned that age has some effect. So younger people don't have as much pain, and also with immunocompromised people that they may not have as much pain. So is it clear what is actually really causing that pain and why it's less when you're younger, or if you have a sort of immunocompromised infection?
Well, I always thought it was related to the degree of inflammation that may be affecting the nerve root, because I've seen plenty of patients, AIDS patients, who've had shingles multiple times, or transplant patients, and they don't really complain of post-herpetic neuralgia in my experience.
So it's thought to be due to damage to the nervous system. And many of us think that if you're younger, you have more sort of reserve in terms of your nervous system. And if you're older, the neurons are more likely to sort of tip over to have really severe damage. So there are differences in, you know, as one gets older in terms of the transport properties, in terms of the axon and all. But again, it's not absolutely clear. There's some scientists who think it's due to persistent virus replication, but I think the majority of the opinion is there's not persistent virus replication, it's damage. And again, the older you are, the more likely your organs and the nervous system is to not be able to repair that damage so quickly.
So why do you think in immunocompromised patients they don't really exhibit post-herpetic neuralgia?
Well, I think the idea is if you're younger and immunocompromised, your organs and your tissues are still more resilient, and you know, if there's damage, it's not going to be as severe. Again, this is a little bit hand waving as I'm doing right now.
Go ahead.
Are there morphologic or other variations to the virus that result in the variation in disease pathology in varicella versus zoster? And I mean, or is that just completely related to the locational infection of?
So as far as I know, a study that my predecessor, Steve Strauss, published in the New England Journal of Medicine, he took care of a patient with Wiskott-Aldrich syndrome who had varicella, and then like 4 or 5 years later developed zoster. They had both isolates, and they just did restriction enzyme mapping and showed that the isolates were identical as far as they could tell. So as far as we know, the virus that causes zoster is the identical virus that causes varicella, and as far as we know, there are no differences in terms of the sequence or in terms of any other properties of the virus.
For most of the vaccine information, I know you mentioned that some people were excluded from the studies who had presented with shingles beforehand. Would it be beneficial for people to get the vaccine once they're of age that have had shingles before? So it's still, I mean, it's still.
Yes. So with time, also the immunity will wane. But if somebody has more recent shingles, because if you remember the bar graphs where it shows up to 3 years, the immunity was similar to vaccine-induced T cell immunity. So experts recommend that perhaps, this hasn't been proven anywhere, but perhaps waiting like 3 years after somebody has an episode of zoster, because they've essentially vaccinated themselves. But to ensure that somebody does receive the vaccine, waiting perhaps like 3 years, and then hopefully they'll get like 10 years worth of vaccine-induced immunity on top of that.
Have they tested vaccines in anyone younger than 50 that you know of?
Not to my knowledge. I don't know. Not to my knowledge.
You want to pass it over, please? While we're passing this, what is there about the dorsal root ganglia of the vagus? Jeff, you said the virus goes everywhere, and in some people it winds up in the cranial nerves, but the predominant distribution is in the dorsal root ganglia of the vagus. What's special about that?
The quick answer is we really don't know. There are differences in these sensory neurons that we're talking about. So there's a transcription factor called HCF1, which seems to be in the cytoplasm of those particular neurons, and it's different than in other types of neurons. And that HCF1 moves to the nucleus when virus reactivates. When HSV reactivates, again, VZVs in the same type of neurons. But the short answer is we really don't know, and people are now taking various monoclonal antibodies and trying to see what's special about those particular neurons, why it's latent there. That's something for the future, for some of the younger people in the audience to figure out.
That's a very exciting area. I was reading recently the evidence that Parkinson's disease may start out as a disease of the dorsal root ganglia of the vagus. Alpha-synuclein accumulates there, and then by magic migrates further up eventually to the basal ganglia. So there must be something very unique about that. Go ahead.
So if a patient comes in with similar skin symptoms as zoster, what are other conditions that may present similar symptoms, I guess? What can physicians confuse zoster with, I guess? That's my question.
Well, as we mentioned, herpes simplex also can present very similarly. So what we do is we unroof the vesicle, and we basically scrape the bottom and put it in media and perform PCR usually to detect the DNA. Also, a contact dermatitis can potentially present as a vesicular-like problem. But what's characteristic is the dermatomal distribution, and classic shingles is pretty classic. But if we're, once we saw a patient who had lesions here, and she said she was told she had shingles, and we unroofed the lesions and did PCR on the fluid, and it was indeed HSV. So it's pretty easy these days to distinguish those two viruses.
Yeah, most of the other rashes will cross the midline, and unlike contact dermatitis, which is localized, as we mentioned, or HSV, most of the other ones would be bilateral.
Okay, well, you have a question, please.
Yes, one last one. I was curious about the tissue-specific localization, and if that's thought to be a factor of viral replication alone, or also maybe localized tissue immunity.
Yeah, so I think, again, the virus is in the bloodstream, which, gets into all the various tissues. And, we'll see patients, and if you measure their liver function test, they'll be a little bit abnormal. The virus, there's a low level of replication of the virus in the liver. So I actually think it gets into most of the tissues and probably replicates to more or less extent in individual tissues. But it's really sort of what we detect when we see patients, or what patients, symptoms or signs from blood tests. And in cell culture, at least, it really infects a vast different, liver cells, lung cells, multiple types of cells. It's very specific for human cells, however.
Are you talking about specific predilection to the nervous system, though, also?
Yeah, I was curious. I mean, because if shingles is reactivating, why doesn't it cross into other dermatomes if it's in the blood? I mean, why is it that symptoms are specific to one particular dermatome? And yeah.
Right. So it reactivates in a single dorsal. It reactivates in one or two, let's say, dorsal root ganglia. Now, there is usually a very, very, very low level of viremia that oftentimes you can only detect by nested PCR, and that's thought to be why some people will have 3 or 4 lesions completely outside of a dermatome. But generally speaking, it's really due to the nerve where it's reactivating from.
Thank you.
Yeah.
Okay, if there are no other questions, thank you both very, very much. Very exciting.